My name is Ines Debove with PMD Alliance, and I'm excited to have this conversation with you today. Actually, we're going to be diving into impulse control disorders. You probably have heard us talk about those before, but today we're going to take a different approach. We're going to take an in-depth look at why these happen, what's going on in the brain, how these can actually manifest for people. You may have heard of gambling and shopping and eating. Those are common, but we're going to dive into additional information that maybe you have heard or not heard before. And we're excited to have a speaker that you have not had we've not had the privilege of having before with PMD Alliance, because she is all the way over in Switzerland. So, so we're excited to have Dr. Ines Debove. She is an experienced neurologist and with a focus on Parkinson's disease and movement disorders, and has been a member of the Department of Neurology at Inselspital, Bern, since 2014. I am trying to not butcher that. And she serves as the deputy head and oversees their deep brain stimulation initiatives at the renowned Center for Parkinson's and Movement Disorders within the University Hospital, Inselspital, Bern. So I am excited to have her joining us. This is actually coming from a paper that she was the lead author on, that was taking a deep dive into impulse control behavior disorders, and it was very interesting. So she is going to highlight that information for you. So Dr. Debove, thank you so much for joining us and for giving us your evening where you are.
Thank you so much, Anissa, for inviting me to this exciting association of yours. And I'm very happy to be part of this educational program. And I'm very happy to see so many online members here. So just in case, I'm very happy to be invited here and to be able to talk about impulse control disorders. And in case if I speak too quickly, please interrupt me anytime. And if you have questions, please feel free to interact. I'm happy about interactive talks with you all. And with further ado, I think I will start with my presentation. So I hope you can see the slides. Great. So I know that a couple of you probably know already about impulse control disorders, but I thought I'm starting with the basics and then building up into the depth, because I don't know where to start exactly, because I think it's a very, probably broad spectrum of people listening to this program today. And so I would like to start with a question to you all. So who among you is basically a Parkinson's patient, and who knows already about impulse control disorders? Perhaps with the first question, if you could raise quickly with the online tool your hand, who of you is a Parkinson's patient? Okay. I can't see everybody, yeah. And who of you already was in contact with or heard about impulse control disorders? Can't see, yeah, a couple of people. I can't see all of you now. And who knows someone who suffers from ICD or who is suffering from ICDs? Please raise your hand or make a sign with the Zoom online tool, just to see. Okay, thanks a lot. That gives me a little bit for the introduction, some help where to start with. So, so I think most of you know already how Parkinson's is going to develop or is developing, but I would like to start that Parkinson's is not a disease which is just touching our motor system, but I think to truly highlight the understanding of it and to show the different loops which we are interacting, I would like to start with a motor loop. So the left side, what you can see is basically illustrating the dopamine. So dopamine is an important neurotransmitter and messenger. It works like a postman, which is working from A to B and helping us basically to get in contact to the different nerve cells and transmitting this information. And in Parkinson's disease, we have the problem, like you know, that this neurotransmitter, which is very important, is going to miss during the course of the disease. And this is resulting in a lack of dopamine and causes the symptoms of the Parkinson's disease. And on the right-hand side, I try to illustrate what is happening if the dopamine is not in balance. So on the one hand side, you have a slowness of movements if you don't have enough dopamine. And on the other hand side, if you get the dopamine and it's basically concentrated too high, you get the dyskinesias. And therefore, I want to show you some videos where you can see a young patient of mine who is 30 years of age, and he is having the Parkinson's disease since the age of 29. So it's an early onset patient. And on the left side, the video I'm going to start now, you can see how he is basically moving without dopamine. And you see the slowness of movement. He can barely basically do the repetitive movements of the hands and has huge difficulties also to move forward, is quite slowed. And then on the right-hand side, he gets the dopamine, and now you can see what is basically happening. And I think this is basically always for me a moment, an aha and very impressive moment when you can see how dopamine goes into the loop of our motor loop and how it changes then suddenly the motricity of a young patient or of an older patient anyway. So said, this is our motor loop. But Parkinson's disease is not just affecting our motor loop, there's much more. And therefore, I want to move over where dopamine is needed furthermore. And you can just see that dopamine, you need that also for the emotional state. And the problem is, if dopamine is not enough in our brain as a neurotransmitter, and if it's too low, you are getting apathetic. Apathetic means that you have a loss of drive. You don't have really the pleasure to do some things because the dopamine is missing. It's like, I would say, an inner motor. On the other hand side, if the dopamine is too high, you get impulse control disorders. That's basically like the contrast when you're basically getting too much dopamine in your brain. And that's the emotional loop. We call it also limbic loop in neurological terms. And the third loop would be our cognitive loop, where you also need dopamine. That means if you don't have enough dopamine as your neurotransmitter, our third loop can be affected. That means also our cognition, our memory functions. And there are many Parkinson patients who complain then about slow thinking because the dopamine is not high enough. On the other hand side, if you have too much dopamine, you can get a flight of ideas, you can get almost too creative, which is on the first place and first scenario, perhaps something positive, but I will show you what happens also if creativity is getting perhaps too much creative. And with that said, I would like to share a conversation I led with one of my patients. She is 40 years old. She's a patient who was affected in the age of 49 with Parkinson's disease. And I asked her in the interview how she basically changed when she got the Parkinsonian medication. And I hope now you can hear a sound. I turned up the volume at the max, but before when I tried it out with Anissa, we had some, I would say auditive issues, but please, listen to it. And otherwise I will repeat afterwards what she said. And it's due to the medication you took from the Parkinson's medication. How was this for you? When were you aware that you have a changing of your behavior? And when did you realize that this was due to the medication or the disease?
Well, I was on Cifrol, also pramipixole, since beginning. and they put me up. At the worst stage, I was up to 4.5 milligrams. And then I did kind of realize myself then that something wasn't right. I was always down in the cellar painting and doing stuff like that, and I was like pushed to do it all the time. I couldn't sleep. I couldn't do anything else. I noticed that, but the other thing I didn't notice was the sex.
So I hope you heard a little bit of what she said. Should I still repeat it quickly, or did you hear everything she said?
I think it was audible. I heard everything. So
Okay.
drop in the chat if anybody needs her to repeat, but I thought it came through pretty clear.
Okay, then I won't repeat it because then it's getting boring. But I just want to highlight what the patient told me, and which is explaining, I think, very well what impulse control disorders are. So under the increase of the dopaminergic therapy, the dopamine agonist, so pramipexole, the patient remarked her self-change of her behavior. And she was basically describing doing handicrafts a little bit more, that she had less sleep during the night because she was doing handicrafts. And she was also describing that she had hypersexuality. Her libido increased during the course of the increasement of the medication. I didn't put that now in further detail, but the problem with her hypersexuality was so, I would say, involving in her private life that at the end the couple split up. So it was a major, I would say, major problem for the quality of life of her and also her husband at this time. And she also described very well that she had the failure to resist the impulse to control these kind of temptation to perform sex or other things, which she described very well in the video. And with that, I wanted to go over to the definition of impulse control disorders, because I think this illustration of the patient described that very, very well. So currently, we can say, I mean, our world is full of temptations. We have to resist a certain extent every day. So I think every one of us has kind of impulse control disorders. So if you ask me and I'm going to a supermarket and I see some chocolate, so in Switzerland, we are very well known for chocolate. And I don't know if you know that. So if I'm going by and I see some chocolate in the supermarket, I would probably take some chocolate with me and buy it, even though perhaps I'm not, or I don't need it at home. But and I think this is a good example to show how our impulses are working. But if someone has a problem to resisting certain of these activities and engages them more and more frequently, even though they are harmful to them, like the bank account or the environment, then we speak of impulse control disorders. So someone who's entering the supermarket, for example, and buying just one chocolate, now he can't resist. He's buying perhaps 3, 4, 5, or 6 chocolates in a row and eating them all up. And this is the meaning of impulse control disorders. So most of the definitions of impulse control disorders I explained with that. So there is one, the failure to resist an impulse or a temptation. Second, the repetitive execution with a lack of self-control, which we call compulsivity. And the third aspect is the negative consequence for the individual or the environment. Like, I would say the bank account, or also like the hypersexuality, which has a negative consequence perhaps on the patient itself, or also on the, I would say the husband or the wife or the spouse, whatever. And now I want to go over, so what kind of impulse control disorders are known and illustrate them. So you see on the left side, the classical impulse control disorders, which were described a long time ago. So the classical ones are hypersexuality, the compulsive shopping, gambling, and some kind of binge eating disorders. And then you have on the right-hand side, I would say the additional impulse control disorders which were added on the further course the last couple of years, which are known as the dopamine dysregulation syndrome, sleep disturbances, and then you have the excessive hobbyism, panding, and creativity. Panding, I'm explaining it with a video later on if some of you don't know what panding is, and also the dopamine dysregulation syndrome. So what is important is to know that approximately 20% of the people with Parkinson's develop an impulse control disorders, which is a high number, I think. So, and it is possible to have several impulse control disorders at the same time. So it doesn't mean that you just have one impulse control disorders. You can have compulsive shopping and gambling at the same time. And it's highly related to the fact how your personality is. So that means if before you were taking Parkinson's medication and you loved to be creative and you drew some things, and then it can be that this creativity is going crazy and over the limit, which is normal. And some persons never develop that. So I think it really is something very individual, and therefore it's also very difficult to track that down. And here I want to share, I would say an impulse control disorders, which on the first glimpse is something wonderful. So creativity. I talked, or I mentioned that before. So you can see the painter. So it's a French patient. She's a painter and sculptor, 61 years old, and she was a former teacher for adults and educator. And she's suffering from Parkinson's disease for 10 years approximately. And you see what kind of paintings she does. So that was in the beginning when she started with the Parkinson's disease, basically the images she was drawing. And then during the course of her disease, you can see how the creativity perhaps changed a little bit. Yeah, that's perhaps also a part of interpretation. But you can see that the motives were getting more consensual and the colors changed. And I would love to read what the patient said about her changing creativity when the medication was increased. And she said, I was obsessed with painting. I started painting from morning till night, often all through the night until morning. I bought a lot of equipment. I used, I don't know how many brushes at once, knives, forks, sandpaper. I would gouge open tubes of paint, and it was everywhere. But I was still in control at that point. And then at some point when the medication, in particular her dopamine agonist, was increased, this happened. So, and I think this image illustrates that very well what happened. So the patient said, at this point, everything became an uncontrollable urge and even an addiction. I would paint any surface I came across. So you can see what she painted. So she basically painted on her washing machine, and she painted all of her cupboards in her apartment. And she had also an expression wall, which she couldn't stop from painting herself every single day and every night in a trance-like state. And this, of course, this is an uncontrollable creativity, which then became destructive to her partner, and all the relations she had. And I think this is something I just wanted to share with you to show how different the impulse control disorders can be and what an impact it has on the private life. And then basically the medication was adapted, and the creativity became new, or again, in a certain kind of manner balanced. And she said also, today my creative work is calmer and more structured, and it's a pleasure for me again and no longer disturbs anyone. And in the beginning, she was basically concentrating on sculptures because she was so afraid of painting again because she had still this addictive feeling to it. And so in the first 1-2 years, she was just concentrating on sculptures until she felt safe. And then she went back to paintings and, yeah, I would say largen up her artistic viewpoint again. And I was talking before also about panding. So panding is something, I don't know how many persons of you now here in, of the participants have heard about panding or what panding is. Can you perhaps quickly raise your hand if you're still with me, if you heard already about panding before? Okay. So panding is a behavior which was firstly described in 2004, which is this publication I want to share with you. And I would just, so the video quality of this publication is not very well because it's so old, but I think it's very illustrative to look what is happening. So you see here a patient who is at home, and she is sorting labels for foodstuffs in the kitchen. And something what you can't hear because the sound is very bad of this video, she ignores an alarm for the next medication dose because she can't stop sorting. She don't want to stop. And then the other segment you can see is another patient at home, and she is also sorting and examining an extensive button collection, what you can see. And you can see that the surrounding is quite chaotic around her, a little bit like with me at my home. But still, yeah, you can see that both of these patients have a kind of stereotype behavior. So this sorting labels or buttons, and this is panding. So it's characterized by an intense fascination with a complex, excessive, and non-goal oriented repetitive activity. And it's very particular with Parkinson's patients. You can't find that in other pathologies. And it can extend to repetitive manipulations of technical equipment, to handling examination or sorting some common objects. I had once a patient who was basically reconstructing and again putting his camera together over hours, over the night, even though the cameras worked very, very well. But it was his repetitive activity without a particular goal, and he couldn't stop it. So now I'm coming over to the therapy. So I think the therapy is, and therefore I showed you before the slides with the different loops. So everything is, you need to adjust the dopamine levels, and they need to be in a balance, because if the dopamine levels are too low, you are getting slowness of movement, apathy, slow thinking, everything what we don't want to be. And on the other hand side, there is a really thin threshold when the tip is tipping over to the other side, when we have too much dopamine. And then you get in the motor loop, the dyskinesias, or you get in the emotional loop, the impulse control disorders, or with the cognitive loop, too much creativity, which could be even addictive. And with this, we basically developed this kind of, we were wondering with different kind of experts, what are basically the treatment recommendations of impulse control disorders. So it was a consensus, an international consensus with, I would say over 20 different Parkinson specialists all over the world. And we asked them how to treat it, because we realized there are no treatment recommendations published so far for ICDs, and not many. And the first thing we argued a lot about was, what are general treatment recommendations? And these were basically our first things we agreed upon. So the first important point is to know, okay, what is timing and urgency of the treatment? So what is the severity of the impulse control disorders? And the severity of impulse control disorders, of course, is something very subjective. If you ask me as a doctor, do I now judge the severity is moderate or severe? Or I ask the patient if his impulse control disorders are moderate or severe. There are two different kind of stories, but this is determining basically the timing and the urgency of treatment. And then the second point was we already upon was, of course, it's important to screen regularly for the ICDs and the related behavior disorders. The third thing was to involve a significant other, like a relative or a care partner. Why? Because, and I think, yeah, probably this is something, yeah, we can take out of clinical practice. We realized, and perhaps you can share also from your own experience, that in most of the cases, we have the difficulty, first of all, also the shame-related topic about impulse control disorders. So there are many patients, of course, who don't want to talk about these topics. And I can truly understand that. I mean, you have a consultation, which is about 30 minutes or 45 or maximum 60 minutes. And then, yeah, the neurologist rushes through different topics. And then he asks you or she asks you about, yeah, do you have hypersexuality? Do you really want to talk about this topic with someone you don't have yet a trustful relationship? And I think therefore also this is really a very challenging topic for us. How can we screen and determine if someone has impulse control disorders? And the partner is very helpful because we have, yeah, a second member beside, and also the reflection of a person who knows basically the patient very well and can give important information to detect this kind of disorders. The fourth thing was that we really truly hope that it is not coming to the point, of course, if there are legal or financial difficulties appearing, we have to admit we are already too late. But then it's important, of course, to involve a social worker or to seek legal advice. And the fifth point is as there are neuropsychiatric problems in the Parkinson's disease, you should really think of consulting and involving a psychiatrist to help with the comorbidities which are present. Okay, so can I move further, or are there any questions? I see someone is raising a hand. If not, otherwise,
So there was a question.
Okay, sorry.
Just literally came in. This one said, in the U.S. we have HIPAA laws. What do you do? And that's our confidentiality laws. What do you do if you are our secondary care partner and the person with Parkinson's does not want to recognize that they have an impulse control disorder and want to discuss that with their neurologist? So if you have somebody like adult child or maybe a friend or just somebody else that's recognizing it, the patient does not want to mention it, and we know that it can be a problem, how do you negotiate that?
I think in general, I try to talk with the patient and to convince the patient to say, okay, look, I would like to talk also with your family members about the Parkinson's disease, as I don't know you so well like your close ones. And it is very helpful for me and to improve your personal treatment if I have the opportunity to talk with your close ones about the Parkinson's situation. And in general, this is something where I would say most of the patients agree that we talk about different kind of topics, because I think due to the time restrictions and also to the insight, at the end, this is very helpful. And I think if we don't have a trustworthy or a trustful relationship with the patient, and we split also within the family, and create some conflicts, this is not going well. So we need to bring everybody on board, which is sometimes effectively very challenging, but I think it's crucial to treat the disease.
Yeah, and sometimes that's because of the stigma associated with the behavior, such as the hypersexuality, or even things like punning. Like if you somehow recognize that that is not typical behavior, yet you can't really stop yourself from doing it, I can see where some people might feel a little bit embarrassed. Is that the case? Have you had issues with people wanting to disclose that they're involved in this kind of behavior?
Yeah, I would definitely say that. So I think there are few patients in the beginning. I think, yeah, at the end it falls with the trust, yeah, to the medical team and also the person who is taking care of yeah, in the whole, I would say, treatment. So at the end, if you have a trustful relationship, then they are, I would say, then you are disclosing also these issues, which is normal. I think if you ask me or someone else, I think you would respond the same. But I think it takes time to build up this trustful relationship and to talk about these taboo topics. And the second thing is, I think, also the inside, which I will touch a little bit later, because I think it's always also gray zone. When do you need to intervene? If someone is apathetic because he has not enough dopamine and feels, okay, my drive is missing, and then you get the medication and suddenly you realize you feel like Superwoman or Superman. That's one patient of mine told me so. She said, look, I was again alive. I was feeling alive with the medication because there were so many things I couldn't do before because my energy was missing. And then suddenly the medication popped in and I realized that I could go out again. I could go out to see friends. I was being creative again. So at what point do you need now to intervene as a therapist and also the close one, because it could become an impulse control disorders if it adds up to a positive quality of life.
We have a lot of other questions, but I'm going to let you go on because you may address them. So I'm kind of collecting those and I can
Okay.
Come back to you.
Okay, perhaps I would just finish one thing, if this is okay for you, for the questions. So I just wanted to show basically the graphic, what the treatment is about, and then I will stop blabbering around and be open for your questions, because this is basically the paper we published, and it's a very simple resume. What we said is important to treat with impulse control disorders, which all the experts agreed upon after 3 times of discussions and surveys, which was quite complicated. Because if you have too many experts on board, you can imagine how difficult it gets, basically. So everybody has his own opinion. So the first thing was we were all agreed upon. So you apply the general treatment recommendations during each visit, irrespective of the severity of the ICDs. And then it's important that you determine the severity of ICDs. And there we basically did in the paper a classification how to classify the ICDs between normal, slight, mild, moderate, and severe. And what is important, we did normally when you see in some papers and the classifications of doctors how they classify problems, the normal is not existing, but we put on purpose the normal inside, because already the changing of normal to slight should basically not alarm, but I would say make us more aware about the fact something is changing, and we need to look and screen regularly to catch the moment when impulse control disorders are going from mild to moderate, because mild and moderate, there are impacts on the quality of life and also the environment, and we want to catch that before. So if we are not able to trace what is normal and what is slight, we can't make this distinction as a therapist, and also the environment. And so I think the main key element of the treatment is the reduction of the dopaminergic medication, in particular the dopamine agonist. And if there are other medications on board, there is a complicated workflow we developed, but I won't bother you with that, just for those who are interested in that. And otherwise, if everything stays stable, you can also just watch and see what happens. You don't need to intervene. So if we have just slight impulse control disorders, we don't need to intervene. We just need to follow up and to screen regularly. And if our adaptation of medication is not helping, then we can consider other treatment strategies like cognitive behavioral therapy, deep brain stimulation, adding antidepressants or neuroleptics, or withdraw even the last medication adjustment before the onset of the ICDs. And that's the resume basically of the paper we did, to make it simple for you. And with that, I would like basically to show the video of the patient I showed you before. Why? So this patient underwent DBS, and I asked her what changed since she had DBS. And for me, it was a very touching and very impressive moment how she shared her experience about the DBS and what changed then with her perspective about the ICDs. And therefore, I would love to share this video also with you all here in the forum.
It took about a year after my cutting down that to realize what was going on. And I am really not a person who doesn't think about myself, but I just didn't get it.
What did help you during this time? So what's
my self-reflection working at me and on me, and talking to my ex-husband and getting up all those things.
So I think for me that was my I learned a lot during this conversation with the patient. So she told me basically in this conversation, after 1 year after DBS, she realized that she had these ICDs, because during the period for her, it was not shame. She told me directly, I was not ashamed of being hypersexual, but it took me really 1 year to realize that I had the problem. So this is the second part. So there are many patients who don't talk about this topic because they feel stigmatized and they're feeling ashamed. But there are a couple also of patients who don't even realize that the problem is appearing. So the insight about the problems are missing. And this is also due part to the medication. And therefore, I think it's important also to involve the close ones. And that's what basically she told me too. So it is self-reflection, but also talking with her partner about the problem, which is helping. And therefore, I think it's very important to address these kind of problems. And with that, I think discussing these kind of stigmatizing and taboo topics, I think we can change also the treatment strategies and help to tailor the treatment better and to be aware about the problems. And I think it's important to discuss that with the team all the time, to be aware how we can adapt the best the treatment. So for me, the Parkinson's disease is more than a movement disorder, and therapy adjustment is really important to keep that all in balance, and they have a major impact on the quality of life, those which are affected and their environment, and they are treatable. So this is my last slide, and I'm open for your questions and very keen what you are asking me now.
So we have a few. I want to go back to, because you mentioned it earlier in the presentation, the dopamine dysregulation syndrome. I'm not sure how much people know about that. If you could delve into that a little bit more. How is that different than some of the other impulse control disorders, and what exactly does that mean?
So dopamine dysregulation syndrome is a problem which is known in Parkinson's disease now also quite a time, and which is part of the impulse control disorders itself. And we define that basically as a problem which is the overuse of the dopaminergic treatments. So people, even though they don't need so much medication, use it in a pathological manner. That means they're using it, yeah, that's like an addicted person. It makes you addicted because you don't feel the need or the lack of dopamine anymore. And it's typical appearing with certain kinds of medication, like the liquid Madopar or the liquid levodopa. I'm not sure how it's called in the US. So in Switzerland, it's called Madopalic. And it's basically used normally as a rescue medication when you're feeling blocked, and then it kicks in within 30 minutes. But at the end, it's also degraded very quickly after 45 minutes to 1 hour. And that means this medication is making, or many patients are getting from that addicted because you feel the rush of the dopamine. It gives you a kick. And then if you go into an off state, of course, it's awful. And you get more of this medication, and it doesn't have the same effect like regular levodopa. So, and therefore, this is part of the dopamine dysregulation syndrome. So we can say it is basically the addictive use of the dopaminergic medication use in Parkinson's disease.
And, you talked about stigma and embarrassment around some of the behaviors, especially when it comes to things like hypersexuality. It's a touchy topic. I know there's been a few comments about it. Somebody mentioned, like, not everybody understands that, even their neurologists understand about these impulse control disorders. And so you mentioned some of the consequences, however, of not addressing them. So those you mentioned were the financial consequences. I'm assuming because people then compulsively gamble or compulsively shop can get out of control. The relationship consequences, it sounds like your lady that you interviewed ended up having at least contributed to marital concerns because of her hypersexuality. And obviously, if people aren't getting sleep because they're punting or compulsively doing something, that can be a problem. Are there other things that people should be aware of from a consequence perspective if they're not addressing it?
I
And
would
it does
say
cause relational strain, because somebody else definitely mentioned that.
I would say that every impulse control disorders, if it gets to an extent where it's called a disorder, has some kind of relational impact on the surrounding. I mean, it depends. And I think the difficulty is always, so if you have someone who is binge eating, for example, I mean, of course you can say the surrounding is not concerned, but if you have persons who are eating that much that they are basically getting with their over their normal weight, corporal weight, and they are eating up all the reserves which are in the fridge, which I had also. So basically the wife was complaining that her husband ate up all the reserves of chocolate and sweets, and was getting quite, I would say, upset, because in the evening she said always, I never have any sweets at home because he's eating up all the things in the evening. And then the next day I realized all our reserves are gone and I have nothing. And I realized that he's getting overweight and getting some medical issues out of that, like cardiac problems, and he can't walk anymore. So this has an immediate impact on the persons, and of course also on the surrounding at the end. And I think this is with every disorder, which I described before. But I think it really depends how it is expressed, and if there are several impulse control disorders at the same time, it can be that several impulse controllers are not having any impact, and that one impulse control or disorder in particular, like sexuality, has a major impact on the life of the couple.
So there was a question, can you please discuss impulse control disorder causes other than dopamine, such as if you're not taking medication, because there was another question, can you have this if you're not taking carbidopa, levodopa? Is there any other causes? Neurodegeneration, cognitive issues?
So you can say that like I said before, everybody of us has kind of impulses and personality traits. But I think the particular thing with Parkinson's patients is that the dopaminergic medication, that means levodopa, dopamine agonists, and other treatments which are available for Parkinson's disease, if they are too highly concentrated, they are making impulse control disorders. And this is really very particular for Parkinsonian disease. But I don't know if you mix it up with OCDs. So OCDs is something else. It's not ICDs. So it sounds like almost the same, but impulse control disorders is not obsessive compulsive disorders.
And I think that gets confused sometimes. Is that different mechanisms in the brain? Different areas of the brain?
Yeah, it's different kind. So at the end, I would say the basal ganglia, which are the deep structures in our brain, they are somehow concerned also with OCDs. But perhaps I go back. So in obsessive compulsive disorders, OCDs, the difference between ICDs is that the OCDs in general, I would say that the difference is pleasure, gratification, or some other reward. So impulse control disorders are related often to motivated behavior like pleasure, gratification, and some other reward. So if you have a creative mood, of course, you are creative. And even if you have an addictive creativity, there is a reward behind it. And for obsessive compulsive disorders, you have repetitive unwanted thoughts, obsessions, and they compel a person to perform like a ritualistic behavior, a compulsion to reduce in anxiety. So this is basically the motivation of obsessive compulsive disorders is different in contrast to impulsive control disorders. I hope I explained that well, what the difference is.
Is impulse control disorders, are they seen in other, like in atypical Parkinsonisms?
Yeah, it's interesting. So you can see it mainly with Parkinson's disease patients, but I think also there are the patients which are well researched because bigger cohorts. And I think the atypical Parkinson's diseases are not so well researched in compulsive behavior. But nowadays, if you look into the literature, it's very interesting. There are cases, and also a certain percentage of atypical Parkinson's are developing impulse control disorders. But I think also the problem is the definition of atypical Parkinson's is that they normally don't respond so well on dopaminergic medication. So I'm just wondering, perhaps the atypical Parkinson's patient is not presenting the ICDs because they don't have so high levels of dopamine, because for the motor symptoms, they are not responding. So the doctors are not describing so much dopamine for them. So perhaps you would find the same things also in atypical Parkinson's, but as they are not treated the same way, you can't find that so often, but it is present.
And I know that your patient in your video had DBS, so it seemed to help because I'm assuming because it was a reduction in medication. Is that always the case? Is there any possibility that having DBS can cause an impulse control disorder?
Yeah. So first of all, it depends. So I know that in the US, you have different targets of DBS. So it depends where you're stimulating. So you have in the US, for example, also the target, which is called the globus pallidus, the pallidum stimulation. And we in Europe, also in the US, use mainly the nucleus subthalamic stimulation, which are two different targets. Why? Why do I mention that? It is that with the subthalamic stimulation, you can reduce the medication. And with the globus pallidus stimulation, which is used, I know, quite often in the US, you can't reduce the medication, the dopaminergic one. It's just that you suppress the side effects of the medication. That means you suppress side effects like the dyskinesias. And that means basically the impulse control disorders, if you use subthalamic stimulation, are decreased. And then your question was if we can also induce impulse control disorders with DBS. Yeah, there are cases. It's discussed also controversially in the literature, because the nucleus subthalamicus has different segments. So you can explain that there are different areas within the nucleus. So you have one part of this nucleus which is important for the movements, and there is also one part which is important for our emotional state. That means if you stimulate too low in this structure, you could even induce and push people to have impulse control disorders. So it's also a question of where are you stimulating, and you could induce them together with the dopaminergic medication.
So we also had a question, this person saying impulse control disorder description sounds similar to the overwhelming desire to move the body and restless leg body syndrome. Could these be causally related or causally related? Sorry, I read that wrong. So any relationship.
Impulse control disorders and restless
leg
legs
that can need to get up and move with restless leg syndrome.
No, I wouldn't say that. I mean, you have a high incidence of restless legs with Parkinson's patients. That's true. So you realize that they have, or there is a certain percentage, so it's not every Parkinson's patient can develop this restless legs syndrome during the course of the disease, even as in a prodromal state. But I wouldn't necessarily put impulse control disorders and restless legs together. Normally, restless legs, just for explaining, when we have a Parkinson's patient with restless legs, we treat that with dopaminergic medication. That means the patient senses then with the dopaminergic medication a certain relief, and doesn't have the urge in the evening or when he or she is sitting in front of the television to move that often anymore. And it's not part of the impulse control disorders. So it's not putting, or you can't put that into the group I showed before. But of course, if you increase then the medication, it can cause impulse control disorders. But I wouldn't say that they are necessarily related to each other in that way. I hope I got your question right.
Okay. Awesome. Well, the only question, and I know you talked about this, Oh, wait, here's another one that's interesting. I'll come back to that. Would you consider sorry, because I know let me go back. I'm jumping all over the place and I apologize. It's just that I don't want to miss
No
people's
problem.
questions. One of them was, I know you did address it. Somebody came back and said you sort of addressed, but they want to clarify, can you have an impulse control disorder if you're not on levodopa, or is this something else? Should they be seeing somebody, having further evaluation if their loved one is experiencing something that sounds like an impulse control disorder, but they're not taking any levodopa?
If they are not taking any levodopa at all, I think it's really important to check it also with the GP before, because it can be something metabolic too. So there are other, I would say, internistic problems which could cause similar behaviors, or perhaps it's also something out of the psychiatric part of it. But normally it's really, I would say, related to the fact taking dopaminergic medication. And it's an overdosage of the dopaminergic medication. It normally doesn't appear without having dopaminergic medication on board, per definition.
Right, thanks for clarifying that. Last question. Would you consider people having a lack of filter when speaking and saying things reactively as being related to impulse control disorders?
Can you rephrase the question, please? Because it was a
Yeah,
little
so
bit
I
complicated
think
from some.
the inability to control things that maybe normally they wouldn't have said. So, sort of that mental filter, but now that mental filter's been lifted and I'll just say whatever's
Yeah.
on my mind.
Yeah, I think this is a really good comparison and explanation. It would be like a filter is taking off. So you have some kind of notions, and this is also what the patient told me. You have a certain personality trait, but you wouldn't. So your personal filter tells you, okay, you don't go over there, and you wouldn't from your personal traits go over to the person and say, yeah, I want to have sex with you, for example. But it can happen if you take the medication, you say things which you would later regret. It's like, I think you can compare this state also with someone who was drinking alcohol. So you feel a little bit disinhibited when you're drinking alcohol. And I think this is something a patient of mine mentioned that too. She said, look, you're feeling a little bit lifted and you do things you probably wouldn't without this medication.
And I know I said that was my last question, but this sort of made me think, since that's not like a real direct manifestation of like one of the impulse control disorders, but the lack of filter. One of the things that I was curious about too is whether somebody might just have fixations, like they get stuck and perseverate on something until that's completed and then move to a new thing and get stuck and perseverate on that. So it's not that they're fixated on one thing only, like sculpting or repetitive button collecting and all that, but like it just depends on, they have a task at hand, and until that task is done they will forsake sleep, eat, or whatever to get it done. Would that be in this same realm?
Yeah, and I would go back again to the personality traits. I think these are persons who have this trait already in themselves. And I'm thinking, so if you're already a person who likes to dive in some certain subjects, yeah, and then you have this trait, and you, for example, I know that my filmmaker, for example, she has also this kind of trait, or artists have this kind of trait, that you have a certain topic and then you dive really deep in and you can't stop it. So if you have this trait, of course, this can be enhanced. But I think a person who doesn't have this trait is having less risk to develop this new trait. So I think these are all traits you have already in yourself, and with the medication, they are getting enhanced, I would say. But yeah, there are also cases where it can appear new. And I think all changing of behavior or new apparition of behaviors which you don't know by yourself and which are directly related to the changing of the medication the doctor did should alarm you.
Well, I want to thank you so much, Dr. Debove, for this incredible talk and delving into this. I know that it's been helpful for a lot of people. It's like Sheila and Jim just said, this is an under-discussed topic. It is a quality of life issue, certainly impact relationships significantly. So thank you for taking the time in your evening in Switzerland to share with our audience here in the United States.
Thank you so much for inviting me. I would have one question to the audience, because I'm struggling always with the fact. So with the filmmaker, we're discussing about doing this year also a film about impulse control disorders. And so we are basically researching now several kinds of areas. And therefore, I would love to ask basically into the audience, how would you recommend to tackle and to trace impulse control disorders? What are your experiences and what are your thoughts about that when you hear about this? Because it's a shameful topic and then there is missing insight. What would you do?
And you're welcome to respond by dropping it in the chat. You're also welcome to, if you have any comments that you would like to share, you can send the email to me and I would be happy to email those to Dr. Debove, and I will drop my email in the chat just in case. Oh, thank you, Kelly. Kelly's quick on it, so she has it. Please copy that. Feel free to share it, and then I will share your information on. Dr. Debove, thank you so much. I have a tradition, or we have a tradition here at PMD Alliance for our speakers. And so this is your first time, so you've not experienced it, but we're going to give you the wave of gratitude. We have people from all across the United States and sometimes outside the US. We're all going to thank you. And I even see a puppy dog giving you a wave as well.
Oh, thank you so much. It was a pleasure to be invited here, and I'm very honored. Thank you so much for inviting me here.
Thank you. And everyone, have a wonderful day.